in again. I'm Jyotirmay, your host, and the series is Fertility Q&A with Dr. Rohit Gutgutia, powered by www.ivfandicsi.com, a website that is designed to help couples navigate their journey to parenthood with informed guidance. Dr. Rohit, welcome back again. In the previous episode, it was about male fertility assessment, and in this one, we are shifting our focus to the male partner. What are the male factors that you're looking for when you carry out fertility assessment for the male partner?
Thank you, Jyotirmay, for having me again. See, I would like to start off by telling all of you that in today's scenario, more than 50% couples are failing to have a pregnancy because of the male partner. So this is something that we don't know or don't really try and comprehend, which is why it is still the standard practice for couples to end up going to a gynecologist if they are not getting pregnant and getting the treatment or let's say assessment started for the female partner. But it is very, very important that the man or the male partner be checked first, because more often than not it is the male partner who is going to carry the reason why they are not getting pregnant, at least in today's scenario. So this is how important it is today that we start with the male partner and try and assess his problems and then go on to the female partner.
So as they say, it takes two to tango, so Absolutely. It is good for couples to keep an open mind when they come for this assessment.
It is good for the couple, for the society and for everyone else to keep an open mind about this. Infertility happens in couples, and both the man and the woman need to be conscious of this and open to this. Thank you, Jyotirmay, for raising this.
Pleasure, doctor. So doctor, what are the tests that the husband needs to carry out as part of his basic fertility assessment?
Yes, so a man has three functions to perform. He should be able to put his semen at the right place at the right time. His semen or sperms, as it were, should be of good quality so as to be able to create a good embryo, and he should be healthy enough to have a child that is healthy. So these are the three parameters or three qualifications or qualities that we look for in a man when we try and assess him.
And what are the tests that you would be ordering for the male partner?
Yeah, so in more specific terms, his ability to engage with his partner sexually is understood by his history, in the sense that when we interview a couple, we try and understand how often are they intimate and do they have any intimacy issues or not. And if that's understood, then we pass on to the most substantial understanding of the male infertility in terms of a semen analysis. So the crux of male infertility evaluation today is actually the semen analysis. Both the sexual function or dysfunction and also the genetic understanding or the overall health of the person understanding is usually carried out in terms of a history taking, interview and indirect ways rather than direct way. The semen analysis is the basic cornerstone of male infertility evaluation, and that needs to be performed properly, and that has a huge significance in terms of our understanding of the male infertility.
Where would you recommend the couples to get this test done? Would you recommend that they could get it done at any diagnostic laboratory, or would you recommend they have this test done at an IVF clinic?
So again, a very, very good question, a very good starting question for me to come back on this. A semen test is testing the body fluid, and conventionally all body fluids, be it the blood or the urine, have been tested in the pathology lab. So we have always thought that the pathology lab is the default place where we need to check the semen sample as well. But while other body fluid testing methods have kept up, the semen analysis method has actually leapfrogged. The methods to assess the semen has changed so many times and so very often. Now it's a very complex and a highly evolved technique to do a good semen analysis. Unfortunately, most path labs do not have the wherewithal, the infrastructure, the trained manpower, the structure to even collect the semen sample properly. It's just not present in path labs. So we strongly recommend that you avoid getting yourself tested for seminal fluid assessment at least in path labs, and go directly to a lab that specializes in semen analysis, which is usually your IVF clinic labs, because that's where the semen analysis is actually carried out in details, which will give us sufficient information to understand the male infertility in the right way.
Doctor, why do you say so?
There are a lot of reasons to it. See, when I was a student, and that's not long back, we were taught that the seminal fluid assessment is carried out in this particular way. We needed a very commonly available compound microscope, we needed a glass slide, and we needed a dropper. A semen sample would be collected, a drop would be taken, placed on the glass slide, and then you would examine it under the microscope. It was a crude method, but that's all that we knew or understood about the semen then, and that is in 1990s. Since then, World Health Organization has actually come out with guidelines about assessment of semen sample, and these guidelines actually get updated every 7-8 years. The last update came in 2020, and that's the 6th edition, and I'm sure there's another update coming in another 4-5 years, and most path labs have failed to keep up with these updates. They're still analyzing by the old method, that is using a glass slide and a low compound microscope to assess the semen sample, which is exactly not the way it should be done. What you need to understand is our understanding of the male infertility, andrology, has actually exploded in the last 30 years, and therefore we need to do a proper semen analysis to make the right diagnosis. Now, in a semen analysis, there are certain components. We need to have proper abstinence, that is, the person should not ejaculate for at least 48 hours prior to giving the semen sample. He should not have a long duration abstinence either, because if he abstains for too long, then his semen will have a lot of dead sperms, and that's going to give us a wrong report. He should collect it properly in a proper wide mouth plastic container, sterile plastic container. He should be able to collect it properly. Most path labs are so designed that they do not have a proper collection room. They just cannot afford that amount of real estate. So they shove the male partner, I'm sorry I'm saying this, they shove the male partner into the washroom, and they do not provide that kind of privacy or the time for the male partner to collect his sample properly. So therefore, usually in path labs, the sample that's get collected is a partial sample or an incomplete sample. Then you're supposed to take out the sample, keep it undisturbed for half an hour so that it liquefies, and then the sample needs to be checked on special counting chambers. Now these counting chambers are, to put it very truthfully, expensive. Most path labs would not want to invest in such expensive counting chambers because the seminal analysis does not come very often to these path labs, and they cannot charge for these semen analysis in the way they should if they were able to do it properly. Unless you use the right kind of counting chambers, the layer of semen that forms on these glass slides is ununiform, and then there is an overcounting that happens in that ordinary glass slide kind of accounting slides, and you get an over report. So that's also not the right thing to do. Then after you've done the counting, you're actually supposed to look at the sperms in much greater details, because you have to look at what is known as the morphology of the sperms, that is the look of the sperm, the shape of the sperm. That can only be done when the sperms are prepared properly, they are stained properly, and then they are magnified under the microscope. Those kind of high magnification microscopes are also usually not available in path labs unless they have bought it for this specific purpose. So all in all, there's no doubt in my mind that a semen analysis that's carried out in an ordinary path lab has absolutely no value in understanding the real pathology affecting that person. So he needs to get it done from a proper place to get a proper diagnosis.
So it's good to know that IVF clinics have proper andrology setups that conform with the WHO guidelines, and they're better equipped to do these assessments than a standard diagnostic lab would.
Exactly, and this is very, very important for all of us to understand and appreciate.
So in a nutshell, what kind of results can you expect from a semen analysis test?
So again, we need to understand that the way WHO has structured the whole thing, they have now done away with normal and abnormals. Now they are saying that this is what is commonly seen and not commonly seen. So they have done away with anything which is normal, abnormal. They are talking in terms of percentile findings, and they say that anything which is less than 95 percentile can be looked at as something which is not right. So this is the language that they are using. They are no longer using normal, abnormal as diagnosis in any kind of the parameters. Having said that, the standard parameters that they have defined, which are getting reformed or redesignated every time that they come out with new guidelines, is the semen volume has to be X amount, the sperm count has to be Y amount, the motility has to be this much percentage, and healthy looking or normal looking sperms has to be this much percentage. Now, how have they come at these numbers? They have looked at recent parents, men who have fathered children in the last 1.5 years, and done a semen analysis for these men across continents, across countries, and then done a statistical average of their reports and come out with these parameters. So the parameters that we are using currently, whether it's the semen volume, whether it's the sperm concentration, whether it's the total count, the motility of the sperm or the morphology of the sperm, these are all fresh. This comes from data analyzed from men who have recently become fathers across continents, and that's how relevant these values are in today's scenario. So when we look at the reports and we see that the values are not matching with the set of recommended values, then we can confidently come back and tell the person concerned that there is a deviation, and we need to look at this deviation and understand why this is happening.
That's good to know, doctor. I came across a very interesting report that semen analysis findings can vary from month to month. So, doctor, can you clarify on this point?
Again, a very, very good point that you've raised today in today's meeting. See, what happens is that the sperm manufacturing process is an ongoing process. The man continually manufactures or grows sperms in his testes throughout his life. Now, testes are organs which are outside the body. They work at a particular temperature, they need a particular environment to work in. If there is something affecting the person, such as a viral fever also, the sperm manufacturing process would be affected as well. And because sperms take almost 2.5–3 months to mature in the testes, the semen analysis report which is carried out today is actually reflecting the sperm manufacturing that took place 2.5 months back. So one semen analysis, even if it is not good, should not put you off. It simply means that today's report is telling you that 2.5 months back the semen manufacturing was not happening properly. You need to do at least 2 semen analyses, if not more, at least 3 to 4 weeks apart, if not more, to get a sense whether the testes are working all right or not working all right. And if there are reports whereas one report is good and the other is not good, we need to repeat another time so that we are sure that this is one-off report that was not correct or not good. If all the reports consistently give us similar kind of results, then we need to understand that there might be something wrong in the testicular function of that person concerned. So one semen analysis report should never be trusted. It should be combined with another report, hopefully from the same lab, from the same person concerned, to maintain parity at least 3 to 4 weeks apart, and then a combination should be looked at to take a definitive diagnosis.
So for those couples who have already carried out a semen analysis test previously and they insist on going by that report, so this answers the question as to why you are asked to undergo the test again when you visit a fertility center.
Absolutely, and it's always recommended that you repeat the test from the same lab just to be sure that the conditions of reporting are also the same. This is something that has to be understood. no two labs would report in a similar fashion. That doesn't make them bad or good. It's just that the conditions of reporting are different. They may have different magnifications in their labs, different machines that are being used, different counting methods that are used. So do not compare reports of two different labs. Please look at the same lab reporting on two occasions rather than two reports from two different labs.
So, doctor, semen analysis is the bedrock of male fertility assessment, and we have very clearly understood why. But then, are there any other additional tests that you might carry out for a male partner?
So, as we mentioned, semen analysis is the bedrock, and all other tests spring from it. So, if the semen analysis is far out from normal, the sperm counts are very poor, very low, then we might think of doing additional tests. Blood tests can be carried out to check the hormonal status of the person. Genetic tests can be carried out to find out if that person is genetically healthy or not. And what we often do is imaging. When you do testicular imaging, you can look for causes of obstruction. You can look at testicular tumors. You can also diagnose what are known as varicocele, which is basically swelling of the blood vessels that come out of the testes. Most of these can be carried out through clinical examination as well, but some of our colleagues may not be comfortable or trained in doing a proper clinical examination of the male partner, so in which case an ultrasound helps. So this would be the additional tests that are carried out in certain cases where the primary test, that is the semen analysis, is not normal.
How does age impact the outcome of these assessments?
Okay, so again this is a very important point that you brought up. Very often and far too commonly we discuss about the impact of age on women, and it's a direct impact. As age increases, the egg count comes down, and the direct outcome from that is lowered chances of a healthy pregnancy. But what we need to appreciate is similar thing affects the man as well. The man also reduces his ability or loses his ability to make sperms or healthy sperms as he becomes older. More and more scientific data is emerging which suggests that a man in 40s is more prone to father children who may be schizophrenic or may have mental issues or may have autism, as opposed to when they father children in their 30s. So we need to keep this in mind. Both the sperm quality and the count gets affected as a man grows older, maybe not as drastically or as radically as a woman, but there is an affection that happens to the aging man as well. So a man in his 40s and 50s needs to look at this information as well before he plans a pregnancy.
Doctor, you did talk about genetic testing, so could you elaborate on what kind of genetic tests that might be ordered, and when would you recommend these tests for the male partner?
So let me share some science with you. So each of us are made up of 46 chromosomes, and out of these 46 chromosomes, 2 chromosomes are the sex chromosomes. If you have 2 X chromosomes in your body, then you are a female. If you have 1 X and a 1 Y, then you are a male. Now in certain males, they may be outwardly male, but they may have an extra chromosome or an absence of a chromosome, and this can only be detected when we do a blood test which is known as karyotyping. So when we do not get a good semen analysis report and we have reasons to suspect, we order the karyotyping test. Also, the Y chromosome, there is a portion of the Y chromosome where there are genes which are the important genes for sperm manufacturing. So if these genes are absent or they have been affected, then sperm manufacturing would be affected and the person may not be able to produce sperms at all, a condition which is known as azoospermia. So when we get men with very low count or almost no sperms, what we call cryptozoospermia or azoospermia, then these men are also suggested a test which is known as Y chromosome microdeletion, YCMD. Now in this test we are looking for deletion or absence of certain genes which are located in one of the arms of the Y chromosome. If these genes are missing, then there is a high chance that we will not be able to make this person a biological father, because his sperms may, even if we find sperms, those sperms may not be able to give us a pregnancy, or in case we are able to create a pregnancy, then there is a chance that his male offspring, his son, may carry the same genetic defect. So then this becomes an important tool for us to counsel the male partner. Then there is something called cystic fibrosis. In this condition also, which usually affects the lung, in this condition also the sperms may be affected and there could be an issue with the sperm quality. So when we have reasons to suspect, we ask for these kind of genetic testing, but as a routine, the first and the foremost test that's carried out is the semen analysis. All the tests which are connected to this spring out of that test only if that report is not good. So this is the whole way the male infertility treatment or assessment is structured.
Doctor, so if everything checks out okay for both the couples, but still they are not able to conceive, then how do you approach this? What happens next for these couples?
So in around 20% of our couples, when we have done the testing, as we discussed in our earlier episode, the male infertility, the female infertility, all the reports are checked out and they all come out to be okay. We still need to keep in mind that these tests are not 100% accurate assessments. They give us the count, they do not tell us about the quality, be it the tubes, be it the egg, be it the sperms. So in case we end up with a situation where all reports are looking okay, but a pregnancy is still not happy, we understand that this could be a case of unexplained infertility. So when we talk about unexplained infertility, what we are trying to tell you is that there could be a quality issue somewhere, but we are not being able to detect that. So we start with a fundamental understanding that it could be some sort of a quality issue, but because testing for those quality issues is going to take a lot of time and it's still not possible in today's scenario, we'd rather try and get you pregnant by either of the processes. We usually start off with an IUI, and if that does not give us the desired outcome, then we move on to an IVF or an ICSI. People who have had sexual dysfunction issues, which is so difficult to make out from patient's history, they would usually conceive with an IUI protocol, and when they do get pregnant, that's when we can make a retrospective diagnosis that they had a sexual dysfunction associated unexplained infertility. And if they don't get pregnant with an IUI and we do an IVF, that's when we first time get to see the egg quality in details, and then we proceed from there onwards. Luckily, most couples with unexplained infertility would also end up pregnant with either of the processes, and while they get pregnant, after they get pregnant, an accurate diagnosis would then be created about why they were not getting pregnant. So in these circumstances, it's a retrospective diagnosis and not a prospective diagnosis.
So doctor, very interesting what you talked about IVF treatment and finding out that along the course of treatment that there are some problems which were not identified earlier. I've heard about tests like DNA fragmentation tests that are done in such cases. So could you shed some light on this test?
Absolutely, very good question again. So when we fail to have pregnancies or we have multiple miscarriages, when the couple is eager to know, and that's a very, very important factor, because many times they are so well read, they want to know from us. So that's when we try and subject the sperms to qualitative assessment. The first thing to remember is all of these qualitative assessments are not standardized. So they cannot be all trusted fully. But they do give us a sense, a trend as you would say. So a DNA fragmentation index assessment of the sperm is one such test. It is assumed that the sperm in its head is carrying all the DNA from the male partner to be deposited in the egg of the female partner, and a pregnancy will happen. Sometimes the DNA inside the head of the sperm may be defective, which is why either the fertilization of the egg is not happening, or even if the egg is fertilizing, the embryo is not happening, or even if the embryo is happening, it's miscarrying. So all of these could happen because essentially the DNA, that's the genetic material that the sperm is carrying, is not healthy, and there is no way we can find out from looking from outside. So then these sperms are subjected to a specialized testing. They are stained in a particular way, and the eggs or the sperms with bad DNA, they stain in a different way, and the sperms with good DNA, they stain in a different way, and that's how you try and find out how many of your sperms which were looking healthy from outside are actually defective. So there are percentages that have been allocated. In most tests, if less than 30% sperms are found to be defective, we consider it to be a decent sample. If more than 30% sperms are found to be affected, then we say that the DNA fragmentation is high.
And what happens then?
Yeah, so then we know why we have failed to get a pregnancy, and essentially that's what we have been looking for. There is not much to do after that because we cannot really change the whole situation, but we know that the DNA fragmentation may be related to the lifestyle, to the underlying processes like diabetes, to obesity, and to occupational exposures like radiation and some chemicals. So we try and correct all that. We put our men through a rigorous course of antioxidants. Maybe they will help repair the DNA damage that's happened to the sperms. And next time around, we try and super select the sperms. We have methods by which we can try and select healthy sperms. There's a method called PICSI, PICI, which is physiological selection of sperms, or there's a method called microfluidics. We try and use these methods to identify good sperms.
So what is this microfluidics about?
Okay, so the standard method of sperm selection is to do with whether the sperms are looking all right or whether they can move in a direction, in a straight line or not. But in case we want to go for super selection of the sperms, then we subject to certain tests. Interestingly, when a couple copulates, when they have sex, more than 50 million sperms are deposited in the vaginal tract, of which less than 1,000 sperms are able to travel up to the egg. So what helps us select these sperms? It seems that the route through which the sperms travel, these are basically microchannels, and they are so designed in the human body that a sperm which is the best aligned, the head and the neck angle, the neck and the tail angle, if it is in the right shape, right structure, then only those sperms can kind of come out through that maze of microchannels and enter the uterus, and through the uterus to the egg. So this is kind of a super selection of sperms that nature is doing. What we have tried to do is duplicate the same thing in our system. Scientists have created a mesh of microchannels. Sperms are deposited at one end, and the sperms which are able to negotiate these microchannels and come to the other end, we assume that these are the healthy sperms and use those sperms to create fertilized embryos through the method of IVF or ICSI, and that's the usage of microfluidics. Basically it refers to very fine microchannels that have been created, and the sperms which are able to negotiate these channels are considered to be healthy sperms.
Doctor, it's very interesting that we have technologies that are trying to replicate the natural selection process as closely as possible.
That's the funny part, that's the good part. Slowly as we learn more, we try and understand and appreciate that how nature has created all this around us, and we are now trying to replicate nature.
So on this note, we come to the end of another engaging session with Dr. Rohit. I hope we have answered all the questions that you were looking for. If you have any further questions, do leave your questions in the comments below. You can also visit our website www.ivfandicsi.com, where you will find a lot of information to help guide you through your process of fertility treatment and parenthood journey. Do tune in to our upcoming episodes. Until then, take care.